Welcome to our presentation. I'm David Fryer. I'm the director of the Cancer Survivorship Program at the USC Norris Comprehensive Cancer Center and the co-director of the Adolescent and Young Adult Cancer Program. And it's really a pleasure to welcome everybody to this session. We presented some of this information a few months ago, and it was well received, and there were requests for a repeat. So we're happy to provide this again. Cancer, the reason for this is important is because among AYA patients, actually young adults with cancer, there is a fairly high level of high presence, a high frequency of genes that may cause an increased susceptibility to cancer. There have been fairly large studies done that have shown this may range about 10% or even a little higher in some studies. And what the importance of this is that if individuals carry that any one of these genes, it may predispose them to a higher risk for developing another type of cancer later on. Different from the first one, sometimes triggered by the treatments, but the treatments in combination with this genetic susceptibility that they may already have. And it might be something that they inherited, but not necessarily. And our genetics experts will be going into that in more detail. The other aspect of this that we'll be covering in this presentation is screening for cancer in general. We know that unfortunately part of being human means as you age and just get more miles on the tires, so to speak, the likelihood of developing cancer for everybody goes up. And that is true for people who have never had cancer, but it's also true for people who have had cancer, even if they don't have a genetic susceptibility. So the importance of that is that individuals who have been treated for cancer at a younger age, even if they don't have a genetic susceptibility to other types of cancer, it's recommended that they undergo the same screening that all of us would as adults, depending on age and sex and so forth. And we'll be going over those guidelines as well. And then at the end of the presentations, which will be given by our nurse practitioner, Jennifer, and also the genetics team, Julie, Jacob, and Becca, we'll sort of circle back and have a panel discussion, and we'll be happy to answer any questions that might come in from the audience. So without further ado, Jennifer, I think I'm turning this over to you.
Okay, thank you. So round of applause to you by attending this webinar. You've already done the first step in protecting your future. So I'm Jennifer Solomon, like Dr. Fryer said. I'm the nurse practitioner for the Cancer Survivorship Program, and I welcome you all. Our objectives is to discuss the following: modifiable and non-modifiable cancer risk factors, cancer screening guidelines, strategies for cancer prevention for lung, colorectal, breast, prostate, cervical, endometrial, ovarian, and skin cancer. Let me just, okay. So positive facts about cancer. Cancer is no longer a death sentence. Some cancers are curable, and if not, in most cases, cancer is treated as a chronic illness. We have the power to try to prevent cancer with lifestyle modifications and screening. So we will start with lung cancer. Lung cancer.
Sorry, Jennifer, you need to share your slides.
Oh, you can't see it?
I can see it.
I can see it.
Okay. 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 So lung cancer risk factors. So tobacco use, occupational exposure to, for instance, radon, asbestos, diesel fumes, air pollutants, and others. Radiation therapy to the chest or breast tissue, history of cancer, especially lymphoma survivors, history of chronic obstructive pulmonary disease, COPD, or pulmonary fibrosis, family history of lung cancer in first-degree relatives, exposure to secondhand smoke, never smokers, lung cancer in never smokers is more likely to be actually among women. But healthcare provider can initiate a risk calculator to enhance determination of risk status. Lung cancer symptoms, early symptoms, if any: cough, shortness of breath, or difficulty breathing. Late symptoms would be hoarseness, hemoptysis, which is coughing blood, atelectasis, collapsed lung, and or pneumonia. Lung cancer screening. Back then, it used to be X-ray. Right now, it is not the gold standard. Now, the gold standard for early detection is low-dose computed tomography, which is low-dose CT scan. So lung cancer screening criteria: 50 to 80 years old and in fairly good health, and currently smoke or have quit in the past 15 years, and have at least a 20-pack year smoking history. This is the number of packs of cigarettes per day multiplied by the number of years smoked. For example, if you smoke 2 packs a day for 10 years, you do 2 times 10, and that's a 20-pack year of smoking. As does a person who smoked 1 pack a day, you times that for 20 years, and that's for if they smoked for 20 years, and that would be 1 times 20, and it would be 20-pack year of smoking. So lung modifiable risk factors: never smoke. If you smoke, quit smoking. Utilize available support resources to quit smoking. For example, 1-800-NO-BUTTS or 1-800-QUIT-NOW. Avoid secondhand smoke. Avoid exposure to asbestos. Avoid occupational exposures via OSHA. Ask your workplace about OSHA guidelines for safe practice. And now we're going to move on to colorectal screening. I do have a lot of rich information, so please pay attention. It's going to kind of be fast, but it's rich information. So colorectal screening. Colon and rectal cancer facts. Death rates have declined over the past 2 decades, reflecting early detection and treatment. There are no symptoms for early colorectal cancer. Hence, screening is vital to detect early stages. Colorectal cancer is a preventable cancer. Colorectal risk factors. Risk increases with age. 90% are greater than 50 years old. Personal or family history of colorectal cancer. Personal or family history of polyps. Personal history of chronic inflammatory bowel disease, ulcerative colitis, Crohn's disease, obesity. Smoking also causes colorectal cancer. Heavy alcohol consumption, diet high in red meat, processed meats, get rid of the deli meats, people. Radiation therapy also to the abdomen and pelvis, or in the spine, the lower spine. And also any history of chemotherapy. Okay, so colorectal cancer screening. So American College of Gastroenterology, ACG 2021 guidelines recommend, it hasn't changed, start colorectal cancer screening in average risk individuals starting at age 45 to 75 years old. The ACG recommends colonoscopy and FIT as the primary modalities for colorectal cancer screening. Colorectal cancer screening in high-risk adults or high-risk patients, ACG suggests for those individuals with a first-degree relative diagnosed with colorectal cancer or have had an advanced polyp before the age of 60 to initiate colorectal screening with colonoscopy at age 40 or 10 years before the youngest affected relative. So if they had cancer at 45, you would start at 35 screening if it's like your mother, father, first degree relative. So consider genetic evaluation in individuals with familial colorectal cancer burden. Definitely need genetics. So colorectal cancer screening for high risk. This is for personal history of childhood, adolescent, or young adult cancer with a history of chemotherapy without radiation. Colonoscopy starts at age 35 years old or 10 years after receiving chemotherapy, whichever comes first, and continues every 5 years as stated by the National Comprehensive Cancer Center, which is the NCCN guidelines. History of radiation involving abdomen, pelvis, lower spine, which is the whole lumbar, sacral, or total body irradiation, TBI, regardless of the dose of radiation, with or without chemotherapy, you actually start younger. Colonoscopy would start at age 30 years old, or 5 years after treatment, whichever occurs last, and continue every 5 years. Again, this is from the NCCN guidelines. Prevention of colon cancer, diet, low in fat, high in fiber, avoid processed meats, limit red meats, vigorous physical exercise is good, avoid smoking, polyp removal reduces risk of cancer by 80%. Now we're moving on to breast cancer. Breast cancer risk factors, starting your period at an early age or having late menopause, family history of breast cancer, genetic mutations, BRCA1 and BRCA2, high breast tissue density, breast dense tissue. Also, African American women have higher risk of advanced breast cancer at earlier age. Recent prolonged use of oral contraceptives, oral birth control, obesity, post-menopause, physical inactivity, hormone replacement therapy, ionizing radiation such as Hodgkin's mantle radiation, or radiation therapy with exposure to the breast tissue between ages 10 to 30 years old. Also, alcohol use and any diagnosis of any abnormal tissue in the breast. Breast cancer screening for average risk. So if you're 25 years old or greater, but less than 40 years old, clinical encounter and breast awareness. If you're 40 and above, annual screening mammogram. And this is actually new. In March of 2023, the FDA approved supplemental screening for those with heterogeneous or extremely dense breasts. So if you get a mammogram at a facility, the facility is obligated to let you know that you have breast tissue, but it is up to you and your provider to order an ultrasound. But you are, FDA does approve mammogram plus ultrasound for breast dense tissue. So breast cancer screening, high risk, annual screening mammogram with tomosynthesis to begin 10 years prior to when the youngest family member was diagnosed with breast cancer, but not prior to age 30. So let's say your mom was diagnosed or your sister was diagnosed at age 42, then you would get a mammogram at age 32. So those received radiation also between the ages of 10 to 30 years old. If you're less than 25 years old, clinical encounter every 12 months and breast awareness, which would begin 8 years after radiation. 25 years old and older, it's annual screening mammogram, which would begin 8 years after radiation, but not prior to 25 years old. And annual breast MRI with and without contrast can begin 8 years after radiation, but not again prior to 25 years old. So basically, mammograms, MRIs are not done before the age of 25. Before the age of 25 is breast cancer, breast awareness and encounter. So breast cancer prevention, pregnancy before age 20 reduces risk, breastfeeding reduces risk, exercise reduces risk, prophylactic mastectomy for women with strong family history of BRCA1 and 2 also reduces risk. Prostate cancer. Age, the risk for developing prostate cancer increases with age, with exception, 1 in 10,000 men younger than 40 are diagnosed with prostate cancer. 1 in 15 men in their 60s are diagnosed with the disease. Race, ethnicity, African American men and Jamaican men of African descent have the highest incident rates in the world. Genetics, familial, 5 to 10% strong family disposition, BRCA1 and BRCA2 gene mutations, BRCA and other inherited mutations, Having a father or brother with prostate cancer may double a man's risk, especially if the relative was diagnosed before the age of 55. And diet, international studies suggest saturated fats and obesity. A recommendation for early detection. So age 50 for men who are at average risk of prostate cancer are expected to live at least 10 more years. And age 45 for men at high risk of developing prostate cancer. This includes African Americans and men who have a first-degree relative, which is father or brother, diagnosed with a prostate cancer at an early age, younger than age 65. Age 40 for men at even higher risk. That's when they would start with those with more than 1-degree relative who had prostate cancer at an early age. So prostate cancer screening, it's prostate-specific antigen, PSA, which is the blood test. Men who choose to be tested, who have a PSA of less than 25, may only need to be retested every 2 years. Screening should be done yearly for men whose PSA level is 25 or higher, and also a digital rectal exam. So cervical cancer. Smoking and cervical cancer. Excuse me. Cigarette smoking and tobacco use have been identified as cofactors for squamous cell cervical cancer. Tobacco-specific carcinogen cotinine has been isolated from the cervical mucus and genital tracts of women who use tobacco and who are exposed to secondhand smoke. So another way to have cervical cancer is also HPV infection, the human papilloma virus. So the HPV infection, a large majority of cervical cancer, more than 95%, is due to the human papilloma virus, HPV. Most sexually active women and men will be infected at some point in their lives, and some may be repeatedly infected. More than 90% of the infected populations eventually clear the infection. So cervical cancer screening, HPV test only checks for the HPV virus, right? Pap test checks for abnormal cells from the cervix. So you need to know, did I have a Pap test or did I have an HPV test? Because they're two different tests. So ages 21 to 24, there is no screening, but starting age 25 to 65, there are 3 types of ways to get the test. So you can get the preferred, which is HPV test every 5 years, or you can get HPV Pap, which is a co-test together every 5 years, acceptable, and Pap test every 3 years, and which is acceptable. Age 65 and older, no screening if a series of prior normal tests were all normal, then you don't need to do further testing. So cervical cancer prevention, vaccine. CDC recommends HPV vaccination for all preteens, even if they don't have to be sexually active, but they should just get the vaccine. Okay, so all preteens, including boys and girls, can receive the vaccines starting from age 9 to 12 years old. Everyone else through age 26 years, if not vaccinated already, can get the vaccine. Vaccination is not recommended for everyone older than age 20 years. However, some adults aged 27 to 45 years who are not already vaccinated may decide to get the HPV vaccine after speaking to their healthcare provider about the risk for a new HPV infection and possible benefits of vaccination. So HPV vaccination for ages 27 through 45 provides less benefit. Most sexually active adults have already been exposed to HPV, although vaccination does not target all HPV types. So endometrial cancer. Risks: unopposed estrogen, oral estrogen, hormone replacement therapy, obesity, diabetes, hypertension. If you had breast cancer in the past or on tamoxifen, you're at 2 times greater the risk of getting endometrial cancer. Starting periods early at age or late menopause, never having been pregnant or infertility. Failure to ovulate, polycystic ovarian syndrome, PCOS, family history of endometrial, breast, or ovarian cancer, HNPCC, genetic mutation, also known as Lynch syndrome, endometrial signs and symptoms. So for premenopausal women, you're getting your periods and for some reason they start to be abnormal. Menstruation, very heavy, or it's just coming abnormal. Get that checked. Postmenopausal women, you have menopause and all of a sudden you're bleeding and spotting. Those are warning signs. You would report that immediately to your healthcare professional. Endometrial recommendations. So high risk women, HNPCC genetic mutation and other genetic mutations. So begin screening at age 35 years. So endometrial biopsy screening tool of choice. So it's every 1 to 2 years. Okay, endometrial cancer prevention. So combined contraceptives decrease unopposed estrogen by adding progesterone. So it's progesterone and estrogen oral contraceptive. Okay, and control obesity, diabetes, hypertension, avoid foods high in fat, and increase physical exercise. Ovarian cancer. Ovarian cancer risks inherited genetic mutation, BRCA1 or 2, HNPCC syndrome, risk of ovarian, endometrial, and colon cancer, family history, increasing age, often diagnosed after menopause, never having been pregnant, hormone replacement therapy, which is controversial. Ovarian cancer, known as the silent whisperer, most lethal gynecologic cancer. There are no screening recommendations for general population. Ovaries located deep within the pelvis, which makes it difficult to diagnose at an early stage. Ovarian cancer signs and symptoms, greater than 2 weeks, abdominal, pelvic, low back pain, abdominal bloating, pressure and fullness, urinary symptoms, urgency, anorexia, early satiety, GI symptoms, example, indigestion, gas, increasing abdominal girth. All of a sudden you feel like your jeans are too tight, a lack of energy, fatigue. Be aware of these symptoms. Be aware of your body. Skin cancer. There's basal cell skin cancer on the left, top left, on the top right, squamous cell skin cancer, and there's malignant melanoma in the bottom. Malignant melanoma, personal history, family history, atypical moles, sun sensitivity, history of sunburns, tanning booths, occupational exposure, coal tar, arsenic. It can even be genetic to have melanoma. So what do? Prevention. Avoid excessive sun exposure. Apply sunscreen. Wear long sleeve. Wear hats. Signs of malignant melanoma, the ABCDEs. A, asymmetry. One half of the mole doesn't match the other half of the mole. It's not even. B, border, irregularity. Edges are uneven also. It's not in like a nice, pretty circle. C, color, changes, right? Variety of tan, brown, black. Diameter greater than 6 millimeters. And E, elevation, it's elevated. Any new skin growth, discuss with your PCP. Don't just brush it off. And now we are going to move to genetics. Thank you. Becca, you're on mute.
Okay, thank you. Hello again, everyone. I will reintroduce myself. My name's Becca. I'm, again, one of the genetic counselors at Norris, and we'll be discussing hereditary cancer and genetic testing with you all. So I always like to start out by presenting some important information that most cancer is not hereditary. So Most cancer is considered sporadic or familial, and only a small fraction of cancers, about 5 to 10%, are hereditary. And these are cancers that are caused by single gene mutations that run in families. So there are many cancers that we see that are common that are not typically hereditary. Here's some of them, such as cervical, lung, testicular cancer, leukemia, lymphoma, thyroid, liver, with the caveat that unless somebody has a very strong family history of any of these cancers or a combination of cancers, or there's some type of tumor genetic result that is concerning for something being hereditary, which I will touch on in a moment. So there's two different ways that we can study cancer genetics. So what we do as genetic counselors is typically testing for mutations that patients are born with that can cause them to develop cancer later or increase their risk of developing cancer at a later time. And this is typically done through a blood test. And again, this is looking at the genes you inherited from your parents that are in the family. And the results of this have implications for the whole family to understand if there's any genetic risk for cancer that others should be tested for. And again, the goal of this type of testing is to learn more about cancer risks, to undergo appropriate screening and prevention to account for those elevated risks. Another way genetic testing can be done is through testing of a tumor, which is done a lot more frequently nowadays. Typically, this type of test is ordered by an oncologist. It can be a blood test. Sometimes they test the tumor itself, and it looks at the specific genetic makeup of the tumor. And typically, this tells the oncologist how or what medications might be better for the type of cancer that somebody has. And so sometimes the tumor genetic testing results may lead somebody to a genetic counseling referral if there's results that are concerning for something being inherited, but that is not a test that looks for inherited mutations, or the sole purpose is not that. So some kind of red flags that you all can look out for that suggest cancer could be hereditary is an adult onset cancer, which we consider to be like breast, uterine, colon, stomach, or GI cancer diagnosed at a young age, which we consider to be under the age of 50. Ovarian and pancreas cancers are more commonly genetic than others. So whenever we see those cancers, that definitely warrants a genetics referral. Or male breast cancer, again, another rare cancer that's more commonly genetic. High-grade or metastatic prostate cancer, seeing multiple generations in the family that have been affected with cancer, as you can see in this family tree to the right. And seeing one single individual patient who has had multiple primary or different cancer diagnoses throughout their lifetime. So there's a couple of more common hereditary cancer syndromes that we see in the clinic that we'll talk to you about. The first one is called hereditary breast and ovarian cancer syndrome. This is a condition that's caused by a mutation in the BRCA1 or BRCA2 gene. And individuals with this type of genetic mutation have an increased risk for breast and ovarian cancer, mainly, as well as smaller increased risks for other types of cancers like pancreas, prostate, and male breast cancer. So it's important for somebody to know whether or not they carry a BRCA1 or 2 mutation if there's suspicion, because they may be eligible for more frequent breast screening. So we typically recommend that patients with BRCA mutations start breast cancer screening at age 25 and get MRI screening in addition to mammogram screening. There's also consideration of preventative surgeries, such as a risk-reducing mastectomy, which is removing the breast preventatively, or removing the ovaries preventatively, since that's a cancer that is typically hard to detect. And I'll pass it on over to Julie to continue on.
Thanks, Becca. So I'm going to pick it up here for Lynch syndrome. This is one of the other hereditary cancer syndromes that we often can diagnose and can do quite a bit in terms of prevention. I really can't emphasize enough how important it is to identify Lynch syndrome, because there are so many ways to reduce risk once we know that Lynch syndrome is there. So Lynch syndrome is caused by mutation in one of 5 different genes. You can see the listing of genes there, and it can cause an increased risk for colon cancer, endometrial, which is also known as uterine cancer, as well as ovarian. And these cancers, particularly the colon and the uterine cancer, can be early onset, under age 50. So we really want to see anyone for genetic testing who has those cancers diagnosed under age 50, in addition to anyone with ovarian cancer, as Becca said. Now, there's a whole host of, before you move on, there's a whole host of other types of cancer, including really any cancer in the GI tract, like stomach or pancreas, or even urinary tract cancers, like ureter cancer and even bladder and prostate cancer. So, essentially, Lynch syndrome is one where we really want to identify these cases and really we feel really positive about finding this because there's so much we can do. Okay, so what can we do? So earlier and more frequent colonoscopy. So Jennifer did a really good job outlining the colonoscopy recommendations. And as you know, it's every 10 years in the general population. But in Lynch syndrome, we actually recommend, depending on which gene, sometimes colonoscopy every year. So the reason for that is because identifying Lynch syndrome, finding the polyps or precancerous polyps can be taken out, and then it can overall reduce the risk of cancer. So this is where colonoscopy is really valuable. And then also an upper endoscopy, checking the stomach, can be done. And then consideration of preventive surgery and other screenings and risk-reducing measures. Even taking oral contraceptives can be risk-reducing for women with Lynch syndrome. Okay, so Becca told you already kind of who we are thinking we want to see for genetic testing. So this is a general guide, and I know that some of you in this meeting have had a history of cancer yourself. So, but even if you haven't, some of the things to think about are these cancers in your family. So ovarian at any age, pancreatic at any age, breast cancer diagnosed under age 50 or metastatic breast cancer, colorectal or other GI cancer under 50, uterine under 50, and the aggressive type of prostate cancer. So if you have personally had, or maybe have a family history of the cancers above, and there's a cluster of cancer in the family, we may just want to rule out any one of these hereditary conditions. So, and then also so let's say, you have mother with ovarian cancer, or maybe you have mother with breast cancer under 50, you would still qualify regardless if you had cancer yourself. So what we do in genetic counseling is we do pre-test. Typically, our model has been to do pre-test and post-test counseling. So pre-test, we do a full family history. We ask you why you want to do it. We tell you how the testing may be incorporated into your care. We educate you on the genetics and the risk. We explain the test so people know exactly what they're getting tested for. We discuss some of the benefits of genetic testing, but also some of the downsides, like finding an uncertain result or finding something you're not necessarily expecting. And then getting your consent for testing. And then post-test, we talk about the results. We do risk calculations for certain types of cancer, screening recommendations. How often should I get a colonoscopy? How often should I have my breast checked? We answer questions like that. Do I need breast MRI, for example? And then we make even recommendations for family members based on your genetics. Should my brother, should my sister get genetic testing? My parents, my kids, all those things. This is kind of a sample of some of the most important genes that we test for. So Becca and I talked about BRCA1 and 2, which is hereditary breast and ovarian cancer syndrome. We talked about the 5 Lynch syndrome genes, so those are on the left. And then The next columns are kind of our breast and ovarian cancer genes that from the ATM and the BARD1 columns. The column after that are polyp genes for the most part. And then we have skin melanoma, prostate cancer genes in the next column. And then we have all these rare syndromes. And some of you may have had really rare tumor types. And we like to rule out some sort of syndromic cause. So we can do that as well. All right, so what about insurance? People say, well, is my insurance going to pay for this? So genetic testing is actually covered by all major payers, and a lot of people don't really know that, but it includes Medicare, Medi-Cal, all of the Anthems and the Blue Shields and Blue Cross, United Healthcare, et cetera. So the only thing is they have specific criteria to be met. If you're within the criteria that was listed on the previous slide, I don't think there's going to be a problem. If you're not, it's still likely your insurance will cover it. If you have co-pays, as for lab tests and so on, that usually is applicable. But one of the nice things is that if you have large out-of-pocket costs, the labs offer this really nice self-pay option of $250 if your insurance is just inadequate. And we even have some resources in our genetics program for certain cases where we actually have support from a foundation to help pay for it. And so I actually really like this slide. It's really old school, but it just kind of reminds us that, there's so many people in the family that can actually benefit from this. But also genetic testing is not for everyone. Sometimes people find that their relatives are immediately wanting to do testing if there's something found like a mutation in the family, and others have a lot of concerns. And so it's one of those things that we want to make sure that testing is the individual's choice. The other reason I like this slide is because there's a 1996 reference from Karen Lerman, who's our cancer center director now at USC, and that's like almost a 30-year-old paper. All right. So in conclusion on this part of the talk, about 5 to 10% of cancer is hereditary. Certain cancer types can be associated with hereditary syndromes. Genetic test results can influence cancer screening and prevention. It's an important tool for cancer survivors and for their family members, and that the knowledge of family history can be very valuable because then we can identify who needs genetic testing. All right, next. Jacob and I are going to talk about some kind of hot topics in cancer detection and some technologies that are not usually offered in clinic, just that you may have questions about or may have heard of and just kind of want to know some of the facts. So I'm going to be talking about whole body MRI, and Jacob is going to be talking about liquid biopsy. Okay, next. Okay, so whole body MRI is not a standard of care. There's pretty much only one syndrome, Lee-Fermani syndrome, where it is part of routine guidelines to get whole body MRI. There are a couple other hereditary syndromes where we would like to have whole body MRI, but we don't really get it yet. But the technology and the procedures can vary widely, but it is something that is sort of out there. You can go to different websites and Google that and find that there's services right near you that are offering these whole body MRIs. So one of the things to keep in mind is getting an MRI at one of these places may not be of the same quality as getting it at, say, USC Keck. Technologies and procedures, the radiologists who read them can vary widely. Also keep in mind that they're screening tests, which means they're subject to false positives. So you may get a scare and find out that it's nothing. But once an abnormality is detected, a dedicated MRI of that organ is usually ordered. Next slide. So in terms of cost, this is not something that's covered by insurance, and it usually are very, very expensive, like about $2,500. Also keep in mind, if your MRI is normal in 1 year, it's just a snapshot in time. So next year you could have something, and unfortunately, that is a recurring cost. There are some specific screens that we've talked about, Jennifer talked about, that are actually better at and more sensitive at detecting cancer, like colonoscopy for colon cancer, mammograms for breast cancer. So whole body MRI would never replace any of those. We'd still recommend doing those and not just relying on it. Also, just having your regular self-exams and physical checks are also essential. So you have to really be vigilant, even if you are doing this. This is, again, an emerging technology and a little bit controversial because it hasn't really been proven to be beneficial, and it is just so expensive and not covered by insurance. Still can be popular. Okay, I'm going to pass it over to Jacob now, and he's going to explain liquid biopsy.
All right, great. Thanks, Julie. So if you haven't gotten the hints, it's very important to do the screenings that are recommended and available. And you can see some of those highlighted here. Actually, the organs that we can screen for which there are recommendations are colored here. So, of course, mammograms and breast MRIs and so forth for those who qualify, low-dose CT scans for those at increased risk for lung cancer based on smoking history, colonoscopies for colorectal cancer screening, PSA and digital rectal examination for prostate cancer screening, and HPV and cervical cancer screening as well. But, that does not include most of the at-risk tissue that makes up our body. And so there's a lot of gray here that you can see, and that basically indicates many of the organs for which we don't have viable screening options. Next slide, please. So, and while these screenings are recommended, I think, there's unfortunately not everyone's getting the screenings that are recommended, and they're still not available for most cancer types. There's obviously some downsides to some screenings. They're not always fun. They are sometimes invasive, and there might be low doses of radiation exposure. There's inconvenience in preparation. There's false positives. The benefits of the screenings that are recommended are thought to outweigh some of these sort of, if you want to call them challenges, but still that, it's important to get them. There have been some companies that have sort of thought about how we can be offering screening more universally for multiple different cancer types with not subjecting people to some of these invasive techniques. And the way that some companies have sort of devised this happening is, and you can advance the next slide, but through something called a liquid biopsy. So a liquid biopsy, as you can see in this diagram, is actually commonly used for people who have cancer to profile those cancers to assess prognosis, treatment response, and then recurrence as well. But newer technology has sort of harnessed this for looking at cancer signals in the blood that might be able to detect cancers at an earlier stage. And actually, what's sort of an interesting aside to this is that similar technology is used for women who are pregnant to screen for chromosomal abnormalities because the fetus sheds DNA, and this was actually part of how this was all discovered. But it's an emerging technology that we're able to look for cancer signals in the blood. And there's currently one clinically available test, and you can advance the slide, from a company called Grail called the Gallery test. And so as you can see in this diagram, tumor occurs somewhere in the body, and it will shed DNA into the bloodstream. That DNA is taken with a simple blood draw and isolated from the blood, and then analyzed for certain DNA signatures. This all goes into an algorithm that helps the scientists at this particular company determine whether or not there is a cancer signal detected, and they can, in most cases, identify which organ that cancer is from. And many people who are pursuing this testing are, of course, not getting any cancer signal, and then there would not be additional workup that's recommended. Next slide. So what's sort of interesting about this technology is that it's specific, which is good, meaning that there's not so many false positives. So there's 0.05% false positive rate, but it's only about 50% or just about 50% sensitive, meaning does a person who has cancer test positive with this test? And the sensitivity for the cancer sensitivity depends on which cancer type we're investigating. And you can see an array here of multiple different cancers that this screening multi-cancer early detection test or liquid biopsy test can identify, and they range widely in the sensitivity, with the most some of the most sensitive cancer types being the liver, bile duct, head and neck, and some of the least sensitive being the thyroid and prostate. Next slide. So the sensitivity of cancer signal detection, you can see here, is amongst all cancer cases, as I just mentioned, around 51%. But they have actually grouped 12 cancers that account for most US cancer deaths, and found that they can actually identify 76.3% of these cancers with using this testing, this liquid biopsy. Next slide. But what's interesting is that, that the stage is directly relates to the sensitivity of the cancer signal detection, as you might imagine. An early stage cancer is most likely shedding less DNA into the bloodstream, is not as likely to be detected as an advanced stage 4 metastatic cancer, where for all cancers collectively, the sensitivity would be 90%. And you would think that typically, and in most cases it's true, typically we want to catch cancers at an earlier stage so that we can find them at the most treatable stage, and that will improve outcomes. But this year, actually, Grail, the company that has this test on the market, published in JCO actually an application of this where it could help in not over-treating people with certain types of cancer. And one of those is prostate cancer. So as we saw earlier, the sensitivity for especially early stage prostate cancer in this screening test is very low, but this test is actually better at detecting advanced prostate cancer. And so if this test can somehow be used potentially in conjunction with the available prostate cancer screening that's recommended, but if a prostate cancer signal is detected here with this test, that would indicate that most likely it's an aggressive or even more advanced prostate cancer, and one might want to move forward with treatment more readily than, say, an early stage prostate cancer that might have been detected with another screening methodology, but not identified with this testing. So I think there's a lot of thought that's, going into how this screening test can be used in a clinical space, and is continually evolving. Next slide. So there are some benefits, of course, to doing this liquid biopsy for early detection. It's a simple blood draw, as I've mentioned. It has low false positive rates. And it can actually screen for many different cancers at once, including many of these cancer types that we don't currently have screening recommendations for or screening options for. It has pretty good tissue of origin discrimination, and there's a preferential detection of clinically significant cancers. Next slide. There's a lot of limitations to the liquid biopsy for early detection as well. So as you saw for most cancer types, it's not going to catch early stage cancers when they are most treatable. The detection depends on the cancer type and the stage. Also, cost is a consideration. Insurance is not typically covering this. It costs $950. It requires a prescription. And, it's currently being studied as well. And so hopefully some of this improves. The origin of cancer is not always identifiable. Unfortunately, in rare cases, some might screen positive, although it's not so likely. But imagine screening positive and then going through all the stress of thinking that you have a cancer somewhere in your body and being worked up for it. And turns out that the multi-cancer early detection test was a false positive. That would create concern, obviously. And there's certain age groups where this is recommended, or at least can be considered for someone to have this testing, which is 50 people 50 years older, but it's not even offered to people who are younger than 21 or who are pregnant, and it wouldn't be used for someone who's undergoing cancer treatment. And also it's like any screening test, it needs to be repeated over time, and obviously if it's costing near $1,000, that can incur a lot of cost. Next slide. So in conclusion, there are a lot of direct-to-consumer whole body MRI options, but as Julie mentioned, there are limitations, technology vary, and costs can be a major limitation. Liquid biopsy for early cancer detection is a promising new screening test that can detect many different cancer types with a blood draw, but it is still in development and still costly, and hopefully there will be improvements in the future and potentially other ways that this can be applied, such as that example I mentioned with the prostate cancer. This is our team of cancer genetic counselors, both at USC Norris and also at LA General. There are 9 of us. You got to meet, I guess, the 3 right of us, Julie, me, and Becca today, but you know, we work very closely with the rest of the genetic counselors, and we have a great team. Oh yes, I should go back. Sorry, go back to the slide. So and we've actually given talks and had people who have wanted to have genetic counseling or who meet criteria, and or who have previously had genetic counseling, and testing and want to understand the results. And so we do offer appointments. We take self-referrals for those who meet criteria, and you can see some of our contact information there if you want to make note of it. My understanding is, of course, that Shu will be disseminating this recording and can provide her contact information as needed as well. Thank you. I think maybe this is Shu can take it from here, or
Or I'm going to take it. Thank you, Jake.
okay.
Fascinating stuff you just presented. And I wanted to make sure we have enough time for questions too. But I just wanted to quickly introduce, because we work very closely with the survivorship program, and we are the USC, or the AYA at USC program for adolescents and young adults with cancer. We're housed at USC in the Norris Comprehensive Cancer Center, and we have to the next slide very quickly. And that's our team. I wanted to make sure everybody saw our team. Dr. Fryer is one of our co-medical directors, and so is Dr. James Hu. And we have a clinical social worker, Mario Espicia, and our new nurse navigator, Karis Barge. And it's a great team. Myself and Shu is the program administrator, and I am the project administrator. So we have the clinical team that does all the clinical work inside the hospital. They do a fantastic job of working together to address the unique concerns and vulnerabilities of this age group. So it's very specific, things like psychosocial support, fertility, preservation, counseling, cancer support services, and financial assistance for both for inpatients and outpatients treated at USC Norris Hospital. But I just want to make a difference, because we do have the clinical program. In addition to that, we also have the programmatic part of our program, which you and I work on very closely, and that's also for 18 to 39-year-olds, but we're open to Norris patients as well as young adults from other treatment centers. And that makes us kind of different from the rest of the clinical program, but we do have all kinds of services and programs. Our signature 3-day retreat, our zoo day we just had, and some other wonderful different. I'm sorry, Shu, that was another slide. So maybe you want to put that slide. These are the different things that the whole team provides. So, but like I said, our community outreach and supportive programming is open to people other than at Norris. So it makes us a little different from the rest of the clinical team. And that's it. I think that's it. We're just very proud that we provide what we call like a third space. It's a safe place for our young adults, for the programming part, and seminars, workshops, wellness, nutrition, and cooking experiences, self-expression workshops, and signature in-person programming, like I mentioned, the 3-day retreat, family zoo day, sports activities like our Clipper game that's coming up in March, and the marathon. So this is what we've provided very proudly since 2013. And if you want to learn more about our program, just visit our website at aya.usc.edu. Thank you. And thank you, everyone. I think you need opening for questions, because just a terrific presentation. So great. Any questions? I know I know there were some in the chat. Do you want me to look at them? Is there anything that's still out there that someone needs to be answered? Can they come back online? Is the recording ended? Shu?
Yes, well, end the recording and feel free to turn on your
Yes, they could turn on
camera
it.
and also your
Right.